is well known that not only the electric response of a nerve structure can be recorded, but it is also possible to identify any modification occurring during surgery when the lesion is still reversible. Reducing the risks of complications and helping the surgeon are the main objective of intraoperative monitoring procedures. This is why in acoustic neurinoma surgery, electrophysiology testing of functional parameters both helps to avoid functional lesions and helps the surgeon in selecting not only the most safe, but also the fastest procedures. In the following video, we're going to present surgical planning, instrument location, equipment, electrophysiology monitoring of the brainstem, of the 7th cranial nerve, and of the 8th cranial nerve. Surgical planning is of paramount importance not only to decide the proper operative strategies and tests for each individual patient, but also to improve the level of communication between the neurophysiology nurse and the surgeon. In particular, a properly planned strategy allows timely reactions to the different alarming conditions which might be encountered during the operative procedure. In the OR, all instruments should be located in such a way not to impair free moving about of all staff members. The electrodiagnostic system to utilize will need to have at least 4 data acquisition channels, optically insulated, equipped with both analog and digital filters, and controlled by a multifunction software that allows filing of data on soft and hard copy. Beyond monitoring display of the bioelectrical signal, thanks to 2 loudspeakers, the system provides for acoustic translation of the baseline electric activity and of the alarm signals. The instrument can be controlled by 2-foot switches in case of prompt performance of a test is required. The preamplifier represents a fairly peculiar unit. Beyond the 4 leads for the 4 channels, through use of jumpers, it is possible to add other 4 leads for 4 further virtual channels, so as to allow recording from 8 different leads, even using only one electrode. As for the recording electrodes, it is necessary to have a dedicated needle electrode for direct recording of the nerve in the near-field mode. The other electrodes are platinum subnerval needles electrodes, 10 mm in length. Before surgery, the nurse should prepare adhesive tapes labeled with the code number of leads in order to easily and rapidly identify them in case any change is required. The extension cables of the auditory stimulators will have to guarantee the most ideal conditions for good quality coupling. After having laid out all the necessary recording equipment, the patient's skin is carefully prepped. The recording needles electrodes are then positioned, without forgetting to apply also a few spare ones, and under sterile conditions and microscopic guidance, the needle electrode is finally prepared for the direct recording of the action potential. As for auditory stimulator, it is preferable to use insert ears, which do not interfere with the surgical field. Preferably, the U-shaped insert should be used, which can run along the intertragic groove and will not become displaced, even reflecting the ear flap forward. Once needle electrodes and stimulators have been positioned, the electrodes are connected to the preamplifier. Now the correct functioning of electrodes is checked, first with impedance testing. And then monitoring the amplitude of the baseline electric activity. Finally, the different motor leads of the facial nerves are assessed with the tap test. For monitoring purposes, we employ a piece of equipment with dedicated software allowing for multifunction monitoring and 3 different ABR testing. 1 for brainstem function and 2 more for auditory controls. a fourth channel for motor monitoring of the facial nerve function, and a fifth one for the recording of acoustic nerve action potential. 2 preoperative baseline recordings allow the selection of alarm levels, beyond which an acoustic signal will go off. Let's now examine a few clinical aspects. As far as the facial nerve is concerned, it is possible to identify the course of this nerve structure by means of monopolar and bipolar stimulation. Furthermore, mild types of reversible lesions and moderate reversible lesions as well as irreversible conditions can be detected. At the end of the surgical procedure, the entire functional performance of the facial nerve can be documented. The ABR on the opposite side of the lesion allows monitoring of the brainstem functional activity. This type of recording is therefore and basically interesting from the anesthesiological viewpoint. In case, for instance, the CO2 levels might decrease. Finally, ipsilateral ABR recording provides accurate testing of the acoustic nerve function, as in this case, in which, from a normal situation, we are able to detect an early lesion, which, however, is still reversible in nature. This test is, however, too slow. Hence, continuous monitoring of the direct action potential is preferable, even though this test cannot be considered to be the standard of choice because of the very many technical problems that are often encountered, especially in the proper stabilization of the needle electrode, in which case signal averaging can be used while recording in the far-field mode, but not considering the recording velocity. This very reason actually led us to set up the so-called fast ABR, which joins rapid testing time to relatively easy mode of recording, thanks to the use of digital filters. The recording itself will take no more than just a few seconds. Perioperative monitoring in neurinoma surgery is now carried out in many specialized institutions because facial motor monitoring and auditory function monitoring have gone beyond the limits of experimental laboratories and can today be considered to be enough reliable for clinical use.